know we are in different zones, but I wish a good morning to those who have it, and good afternoon and evening, wherever you are. And please feel free to this knowledge sharing forum of the African Cancer Research and Control ECHO. My name is Annette Nakaganda, based at the Uganda Cancer Institute. I'm a cancer epidemiologist, and I'm also the chair of the steering committee for this ECHO program. I want to really have a special welcome to those attending this Africa ECHO for the first time. We normally run monthly knowledge sharing sessions, but this month of May, because of the pandemic, we decided to have weekly sessions dedicated to the COVID-19 knowledge sharing and practices and how to handle the situation, especially in cancer care. Because we know that knowledge keeps on changing, and we thought we need to keep up to date with the current information and the best practices, and also learning from each other when it comes to this continuously challenging situation. So today's session is specifically about, we want first of all to know about the intended outcomes of the COVID-19 and Cancer Task Force globally, and Julie will help us know exactly what is happening at the global level. And we also want to explore considerations for adapting clinical care protocols to ensure that patients are looked after very well, and the clinicians are guided very well when it comes to cancer care in this pandemic. So thank you so much for coming to this session, and I'm happy that you're all here. And before I invite the first speaker, I wish to remind you that we are going to have 2 short presentations as detailed on the agenda. And then after those short presentations, we shall have a detailed discussion at the end to really brainstorm on the current issues, but as well as the issues raised in the presentations. And I would like now to remind you to mute your microphone, please, if you are not speaking. And if your bandwidth permits, please turn on your video, because we really encourage everybody to see each other during our interaction. And you can use the chat window to introduce yourself, to drop in a comment, or to note your question that will be discussed at the end of the short presentations. And I also want to remind you that we record these sessions, and we always send them out to all of you who have shared the emails addresses with the African Cancer Research and Control ECHO. So at this point, I'm very honored to invite Dr. Amaka Leshibikan. Dr. Amaka is a clinical oncologist at the University of Nigeria Teaching Hospital in Enugu. She's also a national vice president of the Association of Radiation and Clinical Oncologists in Nigeria. She's an awardee of the Africa Cancer Leadership Institute of EOTIC and serves as the co-chair of the Young Africa Leaders in Oncology Special Interest Group in EOTIC. She's an IAEA fellow and is rounding up a master's in clinical epidemiology. Her research interests focus on breast cancer and HPV-related malignancies. She's keen on implementation science, as she believes this is what will propel oncology care in Africa. She has really published a variety of articles in peer-reviewed local and international journals. So Dr. Mamaka, you are welcome, and we look forward to hearing from you and your experience in Nigeria. Thank you so much.
Thank you, Annette, for the lovely introduction, and good morning, good afternoon, depending on which part of the world you're in. I just want to thank you for the opportunity to share our experiences and how we have hoped to change our practice during this COVID-19 era. These are challenging times for everybody, and so we've had to put measures in place to ensure that we continue offering care to our patients while ensuring safety for all the healthcare workers that are within our unit. Next slide, Michelle. Mishka, can you advance the slide?
Sorry, is that not working? Are you not seeing the second slide?
No.
No, we can't see the second slide, Mishka.
Well, anyway, while she gets the second slide up, the second slide is essentially representation of where we are in Nigeria in terms of.
Did that work? Sorry to interrupt.
No.
Not yet.
All right, apologies. Christine, are you able to share from your end?
Okay. Just a minute. Let me get it open.
Apologies, Amaka, just give us one moment.
Yeah. Yeah. Meanwhile, you can continue, Amaka, as you.
Okay. So, like I said, the next slide is just highlighting where we are in terms of the COVID-19 pandemic in Nigeria. It's actually a diagram showing what our epi curve looks like now. We have a little bit over a little bit under 5,000 cases, confirmed cases in Nigeria as of today. Our first confirmed case was on the 27th of February, and it was an imported case. A man came in from Italy, and shortly after arrival in Nigeria was confirmed COVID-19 positive. And since then, in the few weeks, about 4 weeks after that first case, we saw a lot of other imported cases and also affecting their contacts as well. But however, in the last 4 weeks, we noticed that community infection has actually set in. And as of today, the number of deaths is about 164 people. Sample tested now is just a little under 30,000. Next slide. Our case fatality rate as of today is still about 3%. But this diagram just basically, I just wanted to highlight some of the hotspots in Nigeria. Southwest, that big round blob at the southwest area of Nigeria is Lagos, and that is the epicenter in Nigeria with over 1,000 cases seen. And then the second hotspot was recently discovered, that was in Kano. Enugu, I'm not sure if you're able to see, my state is in the southeast. It's actually earmarked with yellow. But what's important to see here is that all the other states around Enugu state also have confirmed cases of COVID-19. That's importantly essential to us because our institution is the only comprehensive cancer center in the whole of the southeast. And we get referrals from all of that area in the southeast and sometimes from the north as well. So which is why it's a source of concern to us, even though our cases as of today, we have only 11 confirmed cases from Enugu, but we know that that could rapidly progress considering that all the states around us have some activity in terms of COVID-19. Next slide, please. So I just want to share a little bit about what our national response has been. On the 28th of February, our nation constituted the Emergency Operational Center, which is, it was activated and is a level 3 activation, which is the highest emergency level in Nigeria, and is closely monitored by the NCDC, which is the National Center for Disease Control, in conjunction with the Presidential Task Force, which are two high policy areas. The Presidential Task Force reports directly to the head of states, that's the president. So their task was essentially to develop rapid dissemination of information to the public. Their response consists of developing rapid dissemination of information to the public, providing test sites and guidelines for the prevention of and control of COVID-19. Before now, we didn't have any site that was able to conduct the testings. And then once we had that first positive case, 2 sites were activated, and this has rapidly been scaled up to now we have 20 sites able to perform the RT-PCR testing for COVID-19. the NCDC has been very aggressive in terms of rapid dissemination of information to the public, and indeed have somewhat exceeded the expectations of most people, because now it's said that in more, I think they've reached about 80% coverage, which is a huge task because we have a lot of people living in the rural setting, but somehow they've been able to reach those people, and there's a high level of awareness concerning COVID-19 in Nigeria at present. Next slide, please. Essentially talking about what the response activities include, which, like I said, establishing activating 20 laboratories all over the country, which is spread around the 6 geopolitical zones. Nigeria has 36 states, and grouped into 36 into 6 geopolitical zones. The response activity includes also deployment of rapid response teams to support responses in all states of confirmed cases. Now, this is in direct consideration of the WHO isolate, adopt, treat, and trace. So the rapid response teams are actually working closely with the state government to ensure that every confirmed case, they are able to trace the contacts of all the confirmed cases, trying to enforce maximum containment, because, and I'm sure with most of the other African countries, our health systems are weak, and we know that they are very fragile, and we don't want to really overburden them. So there's massive influx to try to contain the disease by rapidly picking up all the contact persons of the COVID-19 positive patients. What they've also done that has also helped was the production and dissemination of socio-culturally acceptable patient education material through their website, through social media platforms, regular SMS, and telecommunication lines. They have formed a very good partnership with all the telecommunication lines, so they are able to send out short messages, and this has really helped in disseminating the information throughout the country. Next. So national response includes the first flight restrictions was done on the 21st of March. We had our first lockdown on the 1st of April, essentially in the hotspots in Nigeria at the time. Next slide, please. That was the hotspots at the time included Lagos, Abuja, and Ogun. And then on the 16th of April, we also had a lockdown in Kano. Now, while all these are lockdowns that were instituted by the president, but all the other states in Nigeria also instituted some measure of lockdown. Were not as permanent, as stringent as the ones in Lagos, Abuja, and Kano, but they also had some sort of restriction of movement. But because of our economy, we've suffered quite a lot of heat because of the lockdown. Lagos, like I said, is the commercial hub of the nation, and Abuja is in the Federal Capital Territory. So they've had to implement what is called a phased and gradual easing of the lockdowns. That's on the 4th of May. We're very worried as to the effect of this, because we know that what the outcome of this may portend, but then we have to try to strike a balance between keeping people at home and the economic implications of that. Next slide. So now we're just going to talk a little bit about our own institutions' preparedness for the pandemic. Next slide, please, Christy. So when the directive came from the EOC, our institution, like all other tertiary institutions, set up a COVID-19 response team made up of high-level government, high-level management officials, members of the infectious disease control, all heads of units, and all the other parastatal, all the other units that are involved directly and indirectly with the COVID-19. So they set up the unit, and they were able to develop a triage protocol for COVID-19 within the hospital. We have many entry points into the hospital, so they decided to compress it into one and have a centralized triage point. And this is the protocol for the triage of patients that come into the hospital. That's the University of Nigeria Teaching Hospital. Next slide. So I'll be talking basically about what the multidisciplinary oncology team did, what their response was like. Now, like I said earlier on, this is the only comprehensive cancer center in the Southeast region, and we have patients coming in from all over the southeast, south, and some parts of the north as well. So it's a heavy clinic, it's a heavy unit, and we know that our patients, most of them on radio or chemotherapy, are already immunosuppressed. And so we decided that the MDT unit sat down and assessed. That was on the 3rd of April. We had a 2-hour virtual meeting where we looked at our institution's protocol. We also assessed the level of preparedness for the MDT unit to be able to continue to offer services to these patients while at the same time ensuring the safety of all the healthcare workers within the unit. So during that session, we looked at 3 broad aspects. We discussed 3 broad aspects. We looked at the hospital facilities and the administration and what they offered, what was on ground, and what we thought needed to be put in place for us to be able to achieve our set objectives, which is continue healthcare delivery in a safe and secure environment. So the first thing we did was decided that having that central triage point for all our patients to converge with patients from the rest of the hospital community was not in the best interest of our patients. We decided we know that our own patients are somewhat vulnerable, and then having them in close proximity during the triage with other patients was not in their best interest. So we're able to reach out to the hospital management, and we had a dialogue with them, and we decided we're going to have our own triage center just outside the complex. Now, within that triage center, we have dedicated staff that have been trained on how to triage the patients. Unfortunately, we are not able to screen and do the testing even within the state. So that is a major challenge for us. So we have that dedicated area where we try to do some kind of symptom screening. We also decided we're going to minimize the number of patients in the waiting area by careful scheduling. We have all the time operated a walk-in policy for our patients. So it was going to be a challenge to try to schedule them appropriately. And we had a number that we wanted to see each day, and we tried to peg that number. But as we have gone along, we have seen that that has not entirely worked. But that was the plan at the onset. We also decided to ensure physical distances within the entire oncology complex, but particularly in the chemotherapy suite, because patients have to spend long hours during while they're receiving their chemotherapy. We also considered setting up a network with other oncology departments nationwide and internationally for shared experiences in managing cancer patients during the COVID-19 era. It's rapidly developing. We're all learning at the same time, but some centers have actually gone ahead and have, actually managed COVID-19 patients with cancer. So wanted to quickly bridge that gap and learn from them what strategies they put in place to ensure health care workers are safe while they perform their daily activities. We also decided that we're going to be strict on environmental sanitation, ensure masking and hand washing hygiene, some of these things that were not hitherto in place before. Now, like me, many of my colleagues before that time had not had any formal training in donning and doffing the PPE. So this was a priority for the MDT Oncology Center, that we're going to liaise with the infectious disease unit and arrange for training sessions for personnel within the oncology department on infectious disease protection and donning and doffing the PPE. We also decided that we needed to update our knowledge base periodically because this is an evolving disease, and at that time we didn't know really much of what was happening, what to expect. So we had all those plans in place for the hospital facility and administration. Then for patient care, we decided that it was important to improve patient knowledge on COVID-19, prevention again being the key word, because again, like I said, our health systems are fragile and we do not want to overburden the system. We, like most parts of Africa, I'm sure that many patients would often come to the clinics with 1 or 2 relatives. So we had to try to get the patients to understand the need to, if possible, come alone or at the very least with 1 person. We also wanted to improve communication channels by leveraging on ICT and mobile health. The Federal Ministry of Health had also at the time developed what they call remote health in a box, where it was sort of like a telemedicine portal where patients would call in and have direct consultations with the doctors. For the physician side, what was paramount was to try to reduce face-to-face consultation. But more importantly, we decided that every patient's decision should be prioritized based on the critical appraisal of the risk-benefit ratio. So now more than ever, we are trying to offer personalized care to our patients, weighing the benefits as opposed to the risk of putting these patients on treatment during this COVID era. We know that cancer in itself can reduce the immune system. Also, the treatments that we give would also reduce and weaken their immune system. So we decided that we had to be specific. We needed to critically appraise the benefits before offering these patients treatment at this time. The surgeons decided that they were going to go with the American Society of Surgeons recommendations using this phase 1, phase 2, phase 3 semi-urgent, urgent, and emergency situations in order to use to triage their patients. So that worked with them with the surgeons for the radons and the we are clinical oncologists. So we developed our own set of guidelines in terms of prioritizing those patients that needed radiotherapy, making sure that this would ultimately improve their overall survival and performance status if need be. Palliative care consultations, we decided should be proactive, should have proactive end of life discussions, because again, we did not know how it was going to pan out when we had that meeting in April, and we decided that we wanted to be prepared both from the patient side and the physician point of view. So by and large, these are some of the decisions we reached during that consultation meeting. And in fact, we actually decided to put it in a paper because this was the first one that was done in the country, and it's, we've sent it in for publication. So some of our challenges, can I have the next slide, please? As I've mentioned in part of the discussions, non-compliance is a huge problem. We have, like I said, we have always run a walk-in clinic. So having patients scheduled, there's non-compliance with patients, as with most other centers managing COVID-19, and those that, even though they are not managing COVID-19, but even in this era, there are short supplies of PPE, which we are also beginning to explore. We're also beginning to see. Remote consultations are difficult, not always successful. But what again is really poses a challenge is the disruption of screening and health education. Our patients have characteristically come in late. We have tried to do some advocacy awareness exercise, and patients are now beginning to respond and trying to come in late. So we are not sure how this disruption in the screening and healthcare education will pan out. And we are somewhat concerned about the tsunami effect of having late presentations after this whole thing is over. We don't even know when it's going to be over. This is definitely not a sprint, it's a marathon. So we know that over time, we may begin to revert back to seeing a lot of advanced cases on presentation. Testing capability is also a problem, a huge problem right now, as even though the NCDC is making great strides in trying to expand and activate these laboratory networks, but there's still deficiency in the country. Lessons learned. At the time we had this meeting, that was on the 3rd of April, we looked at various literature and reports that were coming from various centers on what they had done, and we decided to sort of like limit the number of intakes, surgeries, and patients receiving care. In hindsight, considering how it has slowly panned out and how as of now we have just 11 cases in a group, we're somewhat worried that perhaps that restriction was a bit too early. Perhaps we could have made a little leeway to accommodate a little bit more, knowing that, I mean, the cancer doesn't wait for the COVID-19. So in hindsight, we're like, perhaps we should have just tried to maintain services to a larger extent than we did, while trying, of course, to protect the healthcare workers that are offering service. And also cancer awareness and promotion strategies. We've seen what the NCDC has been able to achieve in a relatively short time, in the sense about getting the information out there to almost every nook and cranny of the state. And they have largely been effective in their dissemination of knowledge. So if for cancer advocates, for people working in the advocacy awareness program, I think it's something they need to sit back and look at the strategy that the NCDC employed to be able to achieve this level in such a short time. Next slide. So we have some questions. What is the approach of screening for patients on radiotherapy and chemotherapy in a center with limited testing capabilities at this time? What plans or strategies are in place to catch up on missed screening and early detection programs? And what would be the approach to intervention programs targeted towards early detection programs during the COVID-19 era? Next slide.
Sorry, I seem to be having a problem.
Oh, sorry. It looks like the next slide can't come.
So basically, that's actually the last slide. And like I said, I've just read the questions that we had hoped that we would be able to get answers to at the end of this session. I will just repeat it. What is the approach of screening for patients on radiotherapy and chemo in a center with limited testing capabilities? What plans or strategies are in place to catch up on missed screening and early detection programs? And what would be the approach to intervention programs that are targeted towards early detection programs during this COVID-19 era, where physical distancing and social distancing are a must? Thank you.
Yeah,
Over
thank
to
you. Yeah, thank you so much, Amaka, for this awesome presentation. It is really nice and informative to hear what is happening in Nigeria and the impact of COVID pandemic, especially to cancer and so many others. Colleagues, I want to remind you that we shall have a very good discussion at the end. Just post your question on the chat window or note it, and you'll be able to verbally bring it for discussion. At this moment, I'm greatly honored to invite Dr. Julie Torod to come and give us the next presentation. Meanwhile, I request Christine, can you meanwhile upload Dr. Julie's presentation?
I can do the slides myself if you can give me control. That's fine.
Before that, I really want to introduce Dr. Julie so that everybody knows who you are. Dr. Torod is the Director of Special Projects for UICC, that is Union for International Cancer Control, and currently dedicating time to supporting the World WHO project and the effort for elimination of cervical cancer globally. Julie's passion is in delivering results highlighted by key advocacy wins with UICC and NCD Alliance, detailed in the global commitments to cancer and NCDs in Global Action Plan of 2013 to 2020 and the 2013 Sustainable Development Goals, as well as the 2017 Cancer Resolution. Julie also collaborates with the WHO to update the cancer chapter on the WHO model, Essential Medicine List, and also the first edition of the WHO list of priority medical services for cancer management. With a Bachelor of Science and PhD in chemistry from the University of Liverpool and a postgraduate work in education, Julie entered the health arena and field of oncology through leading clinical trials work across all the phases, that is from phase 1 to phase 4 clinical trials, with a focus on breast and gynecologic cancers, while nurturing an ongoing interest in cancer prevention. So, Dr. Julie, you are welcome, and we are very excited to have you, and please have the floor. Yes, Dr. Julie?
Julie, I think you're on mute.
Oh, yeah. Let me see if I can unmute.
Okay. Can everyone hear me now?
Yeah, we can hear you very well. Sorry.
Excellent. Sorry about that.
We want to. Are you controlling your slides, please?
I hope so. I'm trying to.
Okay, great.
Everyone keeps sending me messages at the moment. I'm sorry.
Yeah.
I am trying to put it in presentation mode. Is that good for everyone now? It looks okay on my side.
Yeah.
Super.
Very well. Yeah.
So thank you very much, Annette, and thank you to Kenko for the kind invite. And I'm more than happy to join the ECHO platform for Africa, and thank you as well to the NCI team for the support. So I'm going to give you a short introduction to the Cancer and COVID-19 Task Force, which is obvious to everyone is a response to the unfortunate times that we are living. Just to take a moment to thank all of you that are healthcare workers working very hard at this time, and to any of you that have loved ones that are suffering with COVID-19 or have lost loved ones, my deepest sorrows to you. But why a COVID-19 and Cancer Task Force? Well, the cancer community, as we've heard very clearly from Amika, it requires a better understanding of the consequences for future prevalence and mortality rates. And whilst we're seeing a lot of short-term reactions from the oncology community, we're also worried about the mid and long-term impact on the oncology workforce, but also what it means for cancer patients. And what is the long-term impact on services, and particularly then cancer outcomes. So a number of us were having the similar conversations, and so we coalesced around the idea of forming a task force to really bring the power of the community together under one initiative. And I think this quote from Diana Safati, who many of you probably know from our World Cancer Congress events at least, she's now working at the National Cancer Institute equivalent in New Zealand. She said it's really an opportunity for us to work together against a common threat. But she also identifies the differences between countries and their capacities and willingness to act, and how important data is, and how important it is to have data-driven decisions. And I think what we've heard in the early period is that there have been a lot of decisions that haven't been driven so much by data, and driven maybe by a bit of panic. And we need to go back to good oncology practice and underpin a lot of the decision making. And I've got a quote here from Werner van der Puy, who many of you know from Ghana and Aortic, and she feels the ability to test and the economic standing could be hindering our fight in Africa, putting both staff and patients at risk. And so I think the Global Task Force is really wanting to try and help those that are potentially later down, behind in the pandemic curve, but in a position potentially to learn from the higher income countries that hopefully are through one peak and starting to move into recovery. So what is the focus? Well, we want a coordinated community response. We want to try and influence the infectious disease community, because what we have seen is a lot of the dialogue at the moment at global and policy level is all about COVID-19 and the impact of COVID-19. And there's not a lot of discourse about the impact on other health conditions. And we saw that ourselves as UICC when we saw the first draft of the EU resolution going to World Health Assembly next week, where there was no reference to other diseases in that resolution. We've been lucky enough to be able to influence that text, and it does now refer to NCDs and other conditions particularly affected by COVID-19. But it shows that our policy makers and our governments were also pretty much in panic mode and not thinking too well. So what do we want to focus on? Well, we want to focus on the immediate impact, trying to assess those and share that data, and also share that experience that we heard from Amika today. How are different communities responding, and what works well, and how can we consolidate that for future reactions? How can we work with the infectious disease modelling community to make sure that cancer modellers can help work together with that community and have a One Health approach to the future policy making and pandemic planning? and how can we assess the impact on healthcare workers and help shape policy and support for healthcare workers moving forward. So I think, yeah, the task force is really working from a point of strength, saying we need to have quality research and quality data behind our decision making, and that a task force like this, bringing all different parts of our community together, is the best way of achieving that. Dorothy Lombe from Zambia is also part of our task force, and many of you might know her. She pointed out that Zambia isn't testing at all. In fact, they're only able to test in the Cancer Diseases Hospital. But we can learn from that, and we can learn from the situations where there is testing, where there isn't testing. So this is the type of experience that we want to try and bring together as a task force and distill into future planning. In initial conversations, we've also highlighted a fourth area where we're already quite concerned, which is the impact on cancer research. And most of cancer research is stopped, clinical trials aren't taking place, implementation research projects aren't taking place. And so we're concerned about the fact that we've got this halting of activity, but we're also extremely concerned about the diversion of funding away from potentially cancer services and cancer research into the COVID area, and that those fundings might not come back very quickly. And so this is very much something that we'd like to track as we move forward. So this is a list of the people on the task force. We are quite proud of the fact that it's reasonably good global representation, also representing different disciplines and different communities, including palliative care as well as prevention, not just the treatment space. I've highlighted the participants from the African region, so we're represented by the president of AORTIC, Bello Mohammed. Dorothy Lombe I've already mentioned, Grace Beck is working alongside her, and Werner van der Puy from Ghana. And this is just a quote from Bello, where I think articulating a lot of the frustration that many clinicians have been experiencing. And the first patient that died in Nigeria returned from abroad with multiple myeloma. They were put into isolation, and there was no thought or consideration about the cancer that this person was living with. It's really sensitized the oncology community in Nigeria to the fact that they need to be very much part of the infectious disease response. And I think this sort of echoes a lot of the frustration of immediate reactions that haven't taken into consideration oncology services. So how are we taking the healthcare worker piece forward? Well, there is a survey already prepared. It's being led by Chris Booth, who many of you might have met at AORTIC in Mozambique. So he's already got ethics approval in his institution, and in the UK there's also ethics approval. So if anyone would like to take this forward in their own institution, then please reach out to Chris. The email is here and also on the last slide. He can give you a package with the protocol and the questionnaire for the ethics committee, and we'd be more than happy to welcome others to this effort. It's being tested in the UK and Canada at the moment just to validate the approach, but they're more than happy to kick that off in the next week or so. I've mentioned the modelling idea, and we really are wanting to build a modelling consortium that can harness the data that we're collecting at the moment, but also for the longer term view. So we had a call for expressions of interest that went out a couple of weeks ago. We've already got commitment from the International Agency for Research on Cancer, the Canadian Partnership Against Cancer, the International Cancer Screening Network, and the actual coalition consortium, will be housed at Cancer Council New South Wales, and many of you will know Karen Campbell, who's done a lot of the modelling work in the cervical cancer space, and her team is already dedicated to taking this forward. This work is being instigated with a view of at least a good 10-year commitment to this space. So whilst we will try and capture and engage in these immediate policy opportunities and discussions, we are looking at this in the longer term. 3 themes have already been established, and we had our first call on Tuesday, and we had 194 expressions of interest from big modelling groups around the world, from different networks, and also from the infectious disease community. So we're now building these working groups. If you're interested in being part of that, if you're interested in the modelling side, there will also be a clinical reference group for this work, and anyone who's interested in joining can let Karen know. We're starting to form this work and start forming the detailed preparations now. So whoever asked me at the beginning, no, I don't have all the answers about what we're doing. It's really in a process in the forming as we're moving forward, but I think we've done a lot in a very short time. So one survey is out in the community at the moment. I call it sort of a helicopter view. We're trying to capture the immediate effects of COVID-19 in cancer centres and on cancer services. We'd like to have a truly global picture, and it's really a place to identify change and look to see where we might need to do more deep dives to inform more specifically, also inform the modelling work. As I said, we would like to share that data back to people in country if they'd like to do a national analysis. And some countries have been successful in getting all of their cancer centres to respond, so they actually do have a nice data set that they can now use nationally. We're also looking at peer-to-peer exchange, and we heard from Amika earlier about some of the positives that might be coming out of this work. We're calling them the silver linings. What have we been doing, forced into be doing, that we actually see as positive change and that we can keep and move forward if we can underpin that with data? That's one area that the task force is really keen on. We're also very much starting on the recovery planning. This is an area where many outside of high income countries feel somewhat left and alone. So there are templates from organisations like NATO for emergency planning, and we're looking to work on one of those to create a sort of template cancer response that can be informed from the data coming forward, but also be a tool that others can use. And of course, we're also aiming to look at the collective advocacy, particularly with a lens on inequities. What we already know is where we know there are inequities in cancer, these are only getting worse through the impact of COVID-19. So we've already done a piece on refugees and COVID-19, and we'll be really trying to make sure that we move as quickly as possible to more of a holistic approach to solving some of the COVID-19 issues at a policy level, rather than this very narrow COVID response that we're seeing at the moment. The last piece that we've done as a task force is also create an intelligence hub. This is really trying to encourage those that have got national data or centre level data to actually publish it. It's a bit of a challenge at the moment because a lot of journals are a bit slower than normal, but the eCancer platform is an opportunity to publish data and get it out there and share with the community. And this intelligence hub is really trying to pull the literature into main domains, looking at risk factors in cancer patients, management during the pandemic, and the impact of lockdown and self-isolation. We're also reaching out to many other groups that are working on COVID-19, and I'm sure you know of several of them, whether it's cancer specific. We know that SIOP has a pediatric group working together. There's a radiotherapy focus group, and there are different organisations like ASCO and ESMO doing cancer patient registries to try and track the impact of COVID-19 on outcomes. So we're trying to create platforms that we can bring that knowledge together and see how we can work together to ensure that the modelling piece can be as robust as possible moving forward. I think one of the last points I'd like to make is in the last week, Dr. Tedros from WHO has announced that his team will be working on non-COVID issues and looking at health impacts of non-COVID services. There will be a cancer response within that. We're pleased to let you know that we're already very connected with the WHO team on that, and Karen Canfell from the modelling group will be representing the cancer story in that emerging planning with WHO. So cancer's definitely in there, and if you'd like to be involved in that and hear more about that, then let us know, and we'll try through our different mechanisms at UICC as well as the task force to share what's going on as that work matures. And then just to my last slide, how to get involved. Well, I mentioned the high-level survey. It is open for one more day. We've extended it a week already, but if you do, we welcome your input. It only takes 10 minutes. That's the average time it's taken for people to fill it out, so not a big deal. And it would be lovely to have more countries represented. So if you can do that, here is the link to be able to do that today. This is Chris Booth's email. If you'd like to join the Healthcare Workers Survey, he's more than happy to hear from you. And this is the email from the New South Wales Cancer Centre, so COVID and Cancer at nswcc.org.au, particularly to join the modelling consortium or hear more about it. Back to you, Annette.
Yeah, thank you so much, Julie. It was really an interesting and exciting, presentation and initiative. It's really very exciting to see that the global task force is coming together to address this at a global level. And thank you so much. So we have about 13 minutes only for the discussion, and I can see so many interesting questions on the chat and suggestions. So I would like to open the floor for discussion. If you have any questions, you can talk it or post it on the chat window. There are questions that were raised in the discussion from the presentation of Amaka. I can project them out. And meanwhile, please, you can ask any question or comment to any dilemmas from the presentation. Thank you. Any question? If no questions, I have some questions I had. One, to ask Dr. Amaka about whether there are any, because you really presented dilemmas, and I see that one of them was about the telemedicine and how to implement it. To me, I think it is something that is very important, especially in this pandemic, as it is not going to be for a short time. So we really need to make sure that we start and build capacity for telemedicine to really minimize the interactions of the patients with the, with the others and the exposure to COVID infection. Anything that has been started on this in Nigeria?
So there's an app. It's called the OncoPaddy, which was developed by a radiation oncologist based in Lagos. So that essentially links people up and then connects them to doctors, oncology doctors, so that they're able to reach out and they don't have to travel long distances. We have, like I said, there are 36 states and there are only about 9 centers spread across the country. So most times people that require expert oncology services will need to travel long distances. So that app has helped to bridge the gap to some extent. Of course, this is not nearly enough because we are still going to be linked up to doctors who are largely unknown to you. But then if we had something that was, for instance, direct from our own institution that we can use to reach out to our patients, that I think would help allay the anxiety that some of the patients feel at this point in time. The other platform that we're able to use now, which is essentially a social media platform, is the WhatsApp, which you're able to use for calls and video calls, and then patients are just able to ask questions. But it hasn't given the satisfaction that we hope, The health in a box system that was launched is operational for just a few hours during the day. So we really need to develop something that more encompassing and that would really reach out and give that. I mean, we're not able to we don't encourage that face-to-face interaction, but we should be able to have a personal touch with the patients. Again, that will help to allay their fears. So that needs to be developed. I know that our institution is still looking to develop that platform, but as yet we haven't. And even when they do develop that platform, internet services are not 100%. The internet penetration in the last 10 years has increased. I think now we're up to penetration, I hear from the that we've seen is about 60 to 70%. But even at that, that is not really the ideal thing that we should be working with, but it's a start. So we know that even when this is up and running, there will still be some deficiencies because, again, of the internet, ability to access the internet for some of our patients.
Yeah, thank you so much.
Maybe
Yeah.
I could add to that, Annette. I mean, this is one of the sort of silver lining areas that some in high-income countries have identified, that they have used e-consultation and telemedicine to follow up with cancer patients, and they'd like to try and retain some of that for some patients, not necessarily for all. So I think it is something to explore if you're currently not using it, because in the longer term it might help. But the opposite of that is that some that are now actually going back to business as usual are seeing that patients aren't coming back. So I don't think you can sit back and just expect patients suddenly to arrive again. So you do need to think about quite a proactive strategy to encourage patients that should be seeing an oncologist to actually come to the clinic. That's certainly what a few are seeing, and you might see that as well with both vaccination and screening campaigns, particularly in Africa. These are campaign days. People might be a little bit worried about joining big groups, even if the infection is no longer dominating. So you might need to adjust your messaging to the community. But just one point, I remember at the end of Amika's presentation saying how wonderfully the Nigerian government had got social media messaging out to the community. And I think we can turn this around and say, well, how can we use those routes and those channels that have been used effectively for COVID-19? How do we keep them and use them for cancer public messaging? And help, and the same with laboratory testing. If these labs are popping up, how do we retain both the workers that have been trained, but also the infrastructure for maybe HPV testing and cervical cancer and other tests that might be needed for cancer? So there's those opportunities to maybe look at for planning for the future. Over.
Yeah, thank you so much. It's really very interesting and a very area that we really have to really start on planning. And because before we even go to the patient, we really need to make sure that the tumor boards in different tumors continue to happen, and we can handle the telemedicine on a case-by-case basis, discussing our patients and knowing whom we can remotely support, who needs to come, and to have really, in Africa, things like you just walk in the morning, even if they are going to see you at 5 p.m. So we really need to make sure that such things really come up well. We streamline the way we work, minimize the time and the hours patients spend at the cancer centers. Only come, be seen, and go. So we still have a lot to do with telemedicine, even in discussing within the tumor boards, how to go about this and handle them case by case basis. I just see we have 5 minutes. Any question? So I see the dilemma about this, the holding of screening programs. Africa has already a high rate of advanced cases, coming, and now it is going to really excavate
Get
the
even.
whole situation. So, anybody with a comment? I don't want to talk.
Hi, Annette. This is Doug Perrin. I have a comment regarding that point and the second question. And thank you all for the presentation. So I'm Doug Perrin. I'm a Leidos Biomed consultant working with NCI Center for Global Health. And one of the things I do is help coordinate the International Cancer Screening Network, or ICSN, that Julie mentioned, joined the modeling consortium for the task force, the UICC task force, to understand a bit the impact of COVID-19 on cancer screening. And one thing that ICSN is doing right now is launching a survey to try to capture some of this information, especially since this is just happening. We moved really fast with the survey and launched it on Tuesday. And I know that Mishka forwarded that to this group. So I know that some of you already contacted us and are already filling some answers. But this is some of the information that we hope to have, capture in the coming months, by the summer, let's say. So hopefully we'll have some preliminary analysis and able to share a bit more with the group about the plans and strategies to deal with the suspension of screening programs. So thank you. And if you're interested in learning more about the survey, you can always contact me. I can share my email on the chat box. Thank you.
Yeah, thank you so much, Doug. That is really very great information and useful. Any
Annette,
more?
sorry,
Yes,
Annette,
please.
Paulette has raised her hand. Paulette, go ahead and unmute if you have a question.
Yeah, that's great.
Okay, hi everyone. This is Paulette. I work with the Clinton Health Access Initiative out of Nigeria. And my question is to Dr. Amaka. Fantastic presentation, as always. I just wanted to flag or to ask, maybe not just for you, but for us to think through, how do we evaluate the impact of COVID on screening, especially for cervical cancer? And as we begin to ease lockdown, how do we then try to ramp up getting back to that? I mean, we're already struggling in terms of screening. Now that COVID has further affected that, how do we quickly start to gain back some momentum is sort of what I wanted to ask.
Yeah, thank you so much, Paulette. Dr. Amaka, can you briefly respond to that?
Hello, Paulette. As you rightly mentioned, we've seemed to be struggling with screening, and now post-COVID, we have two things we have to deal with. Okay, so the healthcare officers, on the one hand, are very they're somewhat reluctant post-COVID, at least from our own end. We've had discussions with our team, and they're a bit reluctant to want to start that activity as of now because they're worried about their safety. And then the patients as well, those that we have also talked to, are also concerned, and they think that they are not immediately sold out on the importance of screening. This is where I said that we seem to have lost the foothold that we're initially trying to get before. So now we have to try to explain to them why the screening services are important and try to win that trust and get them back to start. While we're doing that from the patient side, we also have to build confidence in our healthcare workers and let them know that if they are safe, they can engage in this screening activity. So it's a difficult problem that we face. And long term, we'll see that cervical cancer will now begin to see many more women. If we don't nip it in the bud, we'll see more women coming in with advanced diseases. So I think somebody mentioned earlier on, and like I had rightly pointed out, the first step will probably be to start with disseminating the information again, like we did, encouraging patients to, first of all, understand again the importance of screening, and then subsequently try to encourage them to come back to screening activities. I don't see a surge in screening activities just now. Just like the earlier presenter said, as the lockdown is easing off, our clinics are beginning to be a bit full. But in terms of screening activities, I think that would need a lot more educational information, awareness that would need to go out to try to encourage the women to come back for screening?
Yeah, thank you so much, Amaka. This is really great. And in the interest of time, I'm sorry, we have to close the discussion now. It is at the top of the hours. And members are welcome to continue the discussion on the base camp and to really see how we move forward. So to sum it up, we have really seen how the effect of COVID to the treatment protocols and how we are going to approach treatment, and also happy to learn about the global response towards the impact of COVID-19 on cancer and screening and control and prevention. So now, Mishka, can you please make some announcements or questions about the next week's topic?
Certainly. Thank you very much, Annette, and thank you very much to Julie and Amaka for these presentations. Just to follow up on the discussion around screening, there will be a presentation not next week, but May 28th on the impact on screening and COVID-19 as well. So stay tuned for that. And next week's session will be on palliative care and end-of-life care considerations. And we have Eunice Garanagna, who's here with us today, who will give the case presentation from Zimbabwe, and Zippy Ali from KEPCA will do the didactics. So thank you all very much for joining. And over back to you, Annette.
Thank you, Mishka. That is great. So it looks like we have come to the end of the session. I would like to thank Amaka and Julie for sharing their great experience and for their time today. And thank you all for really joining us today and for attending this session. And I look forward to seeing you next Thursday. Thank you.
Bye, everyone.
Bye, everybody.
Bye.
Bye, everyone.
Bye.
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 Bye-bye.
Bye.